In this next half hour or so, I will discuss the overview of pain in patients with serious illness. So the objectives are to discuss the pain incidence in individuals with different type of serious illness and describe the temporal definitions versus mechanistic definitions for pain and reflect on what are some of the barriers for delivering effective pain management. This quote from Marcia Angel is very poignant and I use it a lot. Pain is soul destroying. No patient should have to endure intense pain unnecessarily. The quality of mercy is essential to the practice of nursing and medicine. Here, of all places, it should not be strained. Now, there may be times that we can't achieve effective pain control for patients, but in this quote, we're talking about patients enduring unnecessarily pain. There's a revised definition of pain from the International Association of the Study of Pain. Many of us may have remembered Margot McCaffrey's definition. Your pain is whatever the patient says it is, whenever they say it is. The International Association for the Study of Pain describes pain as an unpleasant sensory and emotional experience or resembling that associated with actual or potential tissue damage. And I think the important thing to remember is that it can be different for everyone because of the emotional experience. It's a personal experience and it's influenced by various things such as the psychological factors, social factors. And so the actual experience of pain is different from what actually is triggering and causing the transduction of pain from an injury such as a fracture. So it can't just be inferred just because of the activity in the sensory neurons, because it is partly an emotional experience. And through life experiences, individuals learn the concept of pain. You can think culturally, in some cultures, it may not be acceptable to actually report pain, and it's here that we have to respect that there may be cultural differences, there may be differences related to gender, and pain is absolutely, especially in acute pain with an injury, it's an adaptive role. But it still can have adverse effects on function and social and psychological well-being. And so a verbal description is only one of several behaviors to express pain. So just because we have someone who has advanced dementia and can't communicate doesn't negate the possibility that a human or non-human animal experiences pain. Now, when we think about people with serious illness, pain is prevalent in those with cancer, and it's probably the most widely studied. I think that anytime I see a patient who has a new diagnosis of cancer, one of their biggest fears are, am I going to have pain and am I going to die in pain? But not everyone does. But it still remains untreated. Almost 40% still report moderate to severe pain. And more than half the people talk about pain while they're getting cancer treatment, almost 40% after treatment, and 66% report at end of life. And some other studies have talked to up to 75% at end of life. But many people, even without cancer, may experience pain at life. Like I said, about 66% of people with advanced cancer or end of life report pain. But a survey of caregivers of patients in hospice report almost half the patients have pain. And in a survey of individuals that were 51 and older living in a community, 50% had pain in the last year. So we have to think that even if people do not have a life-limiting illness such as cancer, they still may have pain secondary to multiple things. So you think about people with advanced heart disease, they may have pain that's secondary to arthropathies, arthritis. People with neurologic diseases, with Parkinson's disease or muscular sclerosis often experience pain. And in one study, 70% of 20,000 people reported severe pain in an observational study. But those with cognitive impairment reported less pain. Now, is it because they had less pain, or is it the cognitive impairment maybe does not allow them the ability to fully recognize pain? When we think about classifying pain, there's temporal classifications. So first we have acute pain. This is protective. If we were born, or if you have a Mendelian genetic abnormality that you don't feel pain, most people with those abnormalities cannot stay alive because they wouldn't realize their hand was burned when they touched the stove, or their leg was broken when they fell. So it's protective. It lets us know that something's going wrong, and how do we protect ourselves? Now, when we think about chronic, and I say persistent, non-malignant, meaning not cancer, this is usually pain that persists for greater than 3 to 6 months, such as arthritis, low back pain, or neuropathic pain, and it usually doesn't serve a protective function. So when we think about acute pain, this is a subjective feeling because you've got noxious stimulating from a recent damage. So it's protective to reduce further injury. It's a survival mechanism. It can last up to 7 days, and we think about something like when we think of post-operatively, but can take 3 to 6 months, and it usually resolves as the source of pain heals. So when we think about examples of acute pain, we've got our strains and sprains, trauma with fractures, post-operative pain, burns, labor, and childbirth. Now, there are acute pain syndromes in cancer that can be related to the disease or the treatment. So you've got bony metastasis, obstruction, intracranial pressure, post-operative pain. But there are procedures that we do, such as diagnostic procedures and analgesic techniques and therapeutic procedures, that may actually cause pain acutely as well. When we think about chronic or persistent pain, this is usually pain that lasts longer than expected for the healing of tissues. It doesn't seem to have an apparent value. It's not protective of this fact. People that have low back pain, that don't have any instability of the spine with impending spinal cord compression, they're not at danger for more self-injury, but they may experience chronic pain. And it might not be related to any physiologic findings. There may be nothing that you see on an x-ray except for, say, mild arthritis, and that person may be experiencing 10 out of 10 pain. And this chronic post-surgical or persistent post-surgical pain is pain that sometimes happens after the surgery when we would have expected things to heal. So some examples of chronic pain: low back pain, osteoarthritis, and chronic headaches are probably in the top 3 types of pain that we see people experience on a chronic basis. But then you have things like diabetic peripheral neuropathic pain or fibromyalgia, chronic pelvic pain. These are just some examples of chronic pain. But there's also chronic pain related to cancer. So bone pain, you can have people that have bony metastasis, but they might have been treated with chemo and radiation and there's no active cancer, but they still have the sclerotic lesions that cause pain. Joint and soft tissue pain, visceral pain when someone has cancer-related pain with liver distension, paraneoplastic pain that's occurring, say, in the hands and feet, maybe not even related to chemotherapy, but secondary to a distal cancer process. And then neuropathic pain that can have from spinal cord compression, peripheral neuropathies that we see with certain type of chemotherapeutic agents, plexopathy secondary to nerve root compression from a cancer. And cancer treatment-related pain syndromes can be acute or chronic. So some people end up with chemotherapy-induced peripheral neuropathic pain that may just occur while they're receiving treatment. But there are others that it could be lifelong. Hormonal therapy, people that are on hormones for years after they receive treatment for breast cancer may have a lot of arthralgias. Immunotherapy can sometimes cause pain secondary to inflammation of the colon or lung. Radiation therapy, we can see post-radiation and then also surgery. I mean, I have a patient that's got so much metal and hardware in place from surgical stabilization of her fractures for cancer that itself is causing pain. So there's another way to classify pain, which is the mechanistic classification. So is this a nociceptive pain, which can be somatic like cutaneous on the skin, or deeply somatic, visceral, usually related to organs? Or is it a nerve-related pain, neuropathic, either peripheral or central? Or is that person experiencing a combination of nociceptive, neuropathic, and we often see this in chronic conditions. So when we think about nociceptive pain, this can be pain that's arising from the musculoskeletal structures such as bones and joints, and it may be chronic in nature and may have neuropathic components. When we think about fractures, dislocation or compression secondary to a tumor or cyst or bony structure, or sprains and strains, or this chronic neck and back pain. When we think about visceral pain, this is a type of nociceptive, but it's a result of generators, and it can have a neuropathic component. But we think about things like endometriosis or gastritis or esophagitis, irritable bowel syndrome, chronic pelvic pain. Now, neuropathic pain can be really challenging because it's caused by a lesion or disease of the somatosensory system, but you might not even be able to actually see this. Like, so when we think about diabetic peripheral neuropathic pain, where we're thinking that there's some small fiber neuropathy causing the pain, you're not going to see it on generalized scans, and you may be able to do some advanced testing, but still potentially may not be able to see it. So it's really an abnormal processing of the nervous system. And patients describe things like burning, shooting, pins and needles, like they have a painful numbness. And for some people, it's worse at night. And it can cause sensations such as allodynia, so that you cannot even touch that part of the body. One of my patients said recently, I couldn't even stand a breeze on my legs. They were so painful to even any kind of touch or sensation. Or hyperalgesia, where the pain is worse than one would expect, given the situation. Or dysesthesia, where it's like people talk about feeling like ants are crawling on their skin. And then it can be centrally generated. So this is like an injury to the nervous systems, like those who have post-stroke pain or spinal cord injury, multiple sclerosis, Parkinson's disease, or peripherally generated, such as peripheral neuropathy, or people that end up with shingles and end up with post-herpetic neuralgia, or phantom limb pain after an amputation. Complex regional pain syndrome, which is really poorly understood, but did it happen after an injury, where you have pain and sensory changes out of proportion to the injury, or even without apparent injury, often attributed into one limb. But you also can have alcohol, nutrition-induced neuropathy, nerve root compression, or trigeminal neuralgia. And neuropathic pain may arise from a disease state. So when we think about alcohol use disorder or cerebrovascular accident, diabetes, herpes zoster, HIV, multiple sclerosis, Parkinson's, seizure disorder, all of these can potentially be a causative factor for the person's experience of neuropathic pain. Now, there also can be treatment-related cancer pain syndromes that can cause nociceptive or neuropathic pain. So we can have radiation or steroid-induced femoral or humeral head necrosis. Lymphedema, which can cause a lot of swelling and pain. It can cause a lot of nociceptive or neuropathic, or abdominal pain secondary to intraperitoneal chemotherapy or radiation. Or you have the post-surgical neuropathic pain syndromes, or after radiation, or as I talked about, post-chemotherapy neuropathies, which can persist for life. Now, there's this other pain syndrome that's starting to be described in the literature called nociplastic. So when we think about nociceptive pain, when I break my leg, I feel that pain because it's protective and it's actually adaptive for me to feel that so I can myself from further injury. And so it's really, it's got the activation of the nociceptors. Nociplastic pain can happen where there doesn't seem to be an actual assault, like a fracture or a fall or an injury. And there's no clear evidence of actual or threatened damage, tissue damage, but the pain persists. And I often used to think about this as central sensitization or wind up. So basically meaning that there was this increased responsiveness of nociceptive neurons in the central nervous system to their normal or sub-threshold afferent input. Wow, that's a lot of words. So thinking about like I prick my finger, but I feel like all of a sudden that a boulder is now on my finger. So I'm having this exaggerated response to really what's probably not that painful an incident. And when people end up with central sensitization and wind up, it's like continued pain impulses go to the central nervous system and really can lead to changes that can cause chronic pain even after the injury heals. I often talk to patients, it's like almost like things got jumbled and the body is sending out signals that there's still pain even though there's no injury. And it can cause a state of pain that's really unresponsive to most analgesics and often has characteristics of a neuropathic pain. And this can be really, really hard to treat because no matter what you may try, it may not work, especially if there's been this central sensitization or wind-up or this nociplastic pain. And we have to remember that pain is multifactorial. So there can be the physical insult, like when we fracture a leg. But what is the emotional impact? Like when I'm thinking about my patient's mother who just broke her leg, would her perception of pain be a lot worse because here she is at the bedside of her dying son? You know, are there cognitive factors? You know, one's cognition. I think about one of my family members with a dementia. No, I don't have pain at all. But then gets up to walk and says, I can't walk, I have too much pain. You know, are there other sociocultural things? Like I come up with a family or in a culture that it's shameful to report pain or it's a sign of weakness. Are there environmental factors? Like there's even been some studies have looked at, like, you know, if you grow up, you know, around other people with chronic pain, does that predispose that person to the development of pain? Now, who may be undertreated for pain? When we think about older people, they may not be able to report. I've had several patients refer to me who were older that no one wanted to use any stronger pain medicines because they were worried about side effects, and yet one patient who died, the wife said to me, at least the last month, he wasn't in pain. You see, the patient didn't have cancer. He had terrible, terrible arthritis in so many joints, but no one would give him anything stronger than a Tylenol because he was older. You know, but with a little bit of opioid, she says at least his last couple weeks of life, he was not in pain. Women, I mean, is that changing? I'm not sure, because there's always been this perception, because women may report pain more than men, is there this emotional component? Minorities, we know that there's so many inequities of care in our black-brown population. There's multiple studies that have been shown that in acute pain in the emergency room setting, if you compared someone with a leg fracture in the white population versus black or Hispanic population, the treatment is different and not equitable. Children, again, because they can't report, fear of using medications. I've already talked about cognitively impaired, and this is where we have to think about in our pain assessment. We'll talk about next module, how do we make sure that if we feel that patient has a painful condition, that we actually treat the pain. And those with language barriers that can't actually be understood or report pain. Other people that may be undertreated, people with substance use disorder, and this obviously is my specialty, was working with people with serious illness and substance use disorder, and I really worry, especially if people are on methadone or buprenorphine for substance use or opioid use disorder, and then they come in with a fracture and people may not treat their pain, saying, well, they're getting this medication. That medication is to reduce craving, but may not be at a dose that will treat pain. Or if someone seems to be drug seeking, that patient who says, hydromorphine works better for me than morphine. As a nurse, I might be thinking, why do you know the name of that med? Is that person drug seeking? Is that person asking at 3 hours and 45 minutes for a med that's not due until 4 hours? Is that drug seeking or is it unrelieved pain? And those who have been on a prolonged use of opioids or maintenance therapy, say for opioid use disorder, and they may have developed opioid-induced hyperalgesia. And so those are some of the barriers to effective pain management. And it can start in the organization. Is there a lack of recognition of the scope of the problem? Now we have pain, the fifth vital sign that came out, and everyone swung to, potentially using more than probably was necessary of opioids. But we now might swing the other way, where we cause problem because of a lack of recognition, or we don't have policies related to assessment and management that are doable policies that don't involve, don't involve so many procedures that make it hard to treat the pain. And maybe there's a lack of accountability for pain management. If someone does a botched surgery or causes significant harm to a patient, physically, we may see that there's some accountability. But it may not happen if someone just reports untreated pain. And there may be not good quality measurements in, how are we really, besides the 0 to 10, and is someone documenting after a pain treatment, what other quality assessment measures should we be putting into place? And then there's those of us that are healthcare professionals. I think that still in 2022, people do not get adequate education in their medical or nursing education about pain management, really how to really well assess pain beyond this pain severity scale. Lack of a team approach to care, time, insurance issues, personal opinions and beliefs, and then really fears about adverse reactions from opioid use, which is a real fear. And then we have patients and their families that can actually be barriers. There can be the culture, underreporting of pain, really being afraid of analgesics, especially in this age where we have the opioid epidemic. I have so many patients, even with advanced cancer, really afraid to start opioids because very few people I know have not known someone who's had some type of adverse effect secondary to opioid use, or very few have not known someone in their family or friends or community that have died of an opioid overdose. Some people may believe that pain can't be relieved, but some people feel that suffering and pain are necessary. Or they want to be the good patient, like this patient with cancer. Well, I don't want to bother the oncologist about my pain because I want him or her to focus on my treatment. Or there may be the lack of financial resources, transportation, insurance barriers with huge copays, or patients that may just not have insurance to be able to cover adequate pain management options in the ambulatory care setting. So it's really important that we think about improving pain management using a transdisciplinary approach. And what do I mean by transdisciplinary? I mean that all disciplines and all people involved in the care have a say and a voice at the table. This is nursing, medicine, the family, pain service, social work, chaplaincy, psychiatry, psychology, rehabilitation therapy, integrative therapy, like is there healing arts, is there massage? Are these things that we could potentially be offering patients that we're limited now due to the lack of financial resources or due to the lack of insurance reimbursement? So in this brief presentation, I talked about pain that's prevalent in people with serious illness, and then while cancer-related pain has been the most widely studied, pain is often common in people with other serious illnesses. And when we assess the pain, we have to think, just with aging, are there other things that may be causing pain, such as arthropathy, someone who needs a knee replacement or shoulder replacement, hip replacement? And really, to effectively treat pain, we have to recognize what are some of our barriers, either our own personal barriers, secondary to lack of education, patient and family barriers, organizational and systemic barriers to treatment.